how many of you have access to ECMO here? All right, not very many. Okay, so I won't talk about that too much. How many of you here have access to balloon pumps? Okay, and how many of you have access to inotropic agents, and those are usual in CCU and things like that. So what I want to do today is actually review some of the concepts in cardiogenic shock, specifically with regards to management mostly. Now, as you can imagine, the management of cardiogenic shock in our population in North America, for example, is somewhat different than it's going to be in other places in the world. I have had the opportunity to work in different places like South America, visited Colombia, as well as Korea and places like that. So I'm going to try to tailor some of the talk to what you have available as well. So number one, of course, you need to know what the problem is. What is cardiogenic shock? Usual patient that you would see is a middle-aged female or male coming with an ST elevation myocardial infarction, and they usually present either to the hospital or the cath lab in distress. Blood pressure is low at that point, and then the question becomes, what do you do next? In North America, we would assess patients for not only medical therapy, but also revascularization, as well as possibility of mechanical support devices, which I believe you will hear about tomorrow, and of course transplantation as an endpoint as well. So the plan here, of course, is to go over what the definition is. Blood pressure is below 80, lasting for more than 30 minutes in the absence of hypovolemia. And this last part is very important. You can't call somebody cardiogenic shock if they're dry. Until they've actually been resuscitated from a fluid standpoint, cardiogenic shock really doesn't apply. Of course, the wedge pressure on the left side of the heart needs to be elevated, usually 18, and the cardiac output has to be low, in this case, cardiac index as well. And the causes, of course, in the large MIs, RV infarcts, which we talked about a little bit, and mechanical complications. Categorizing shock, vast majority of patients coming in cardiogenic shock will come because of left ventricular failure, either because of acute decompensation related to an infarct or acute decompensation in the setting of pre-existing heart failure. But there are other things, like in the mechanical complications, there's isolated tamponade rupture and things like that as well. But the vast majority that you will see will actually fall in that. And the mortality in these patients across the board is very bad. Most of them have a 50 to 80% mortality from an in-hospital mortality. So oftentimes, no matter what we do, even in the best hands, mortality would be quite high. Until about 15 years ago, we used to think that cardiogenic shock was a very easy thing to understand. You know, your heart dropped, didn't work very well, you filled up with fluid, and your vessels tightened up. What we realized over the last number of years, and Judith Hockman had a lot to do with it, we understand that cardiogenic shock now has a significant component of a vasodilatory inflammatory mediated process. Cytokines, specifically the interleukins, tend to have a very, very important role in the situation. What happens then is some of these cardiogenic shock patients present almost in sepsis. It's not unusual for somebody coming into hospital. There's a discussion between ICU and CCU. Is this cardiogenic shock? Is this septic shock? So they usually go to one of the two, and then they culture them significantly, and nothing grows. They start them on antibiotics, they don't respond, and eventually they might actually die. This is because rather than being in a septic shock situation, what they really have is cardiogenic shock with a significant vasodilatory component related to the cytokines that are going on. As far as basics then, 8% of all STEMIs, or ST elevation myocardial infarctions, will develop shock. Revascularization is important, and based on the shock trials, about 10% reduction in hospital mortality, as well as a 13% reduction in one-year mortality. So if there's the option in a STEMI situation, and somebody's in shock, they should be taken to the cath lab. Inotropic support, vasoactive agents we use very often, but can have long-term harmful effects. And of course, regardless of what we do, mortality remains high. From a clinical classification, the old classification was Killip class. We all understood it was easy. Killip 1, no rails, no S3. Killip 2, he has some crackles in half the lungs. 3 was beyond half of the lungs, and of course, cardiogenic shock was the Killip 4 population. It's not very practical from a standpoint of management. So Forrester, this is in 1976 actually, and Lynn Warner Stevenson since then has actually refined it a little bit, but talk about hemodynamic subtypes in somebody coming in with heart failure. And shock usually falls in a subtype 4, where they're actually cold, meaning they're not putting out enough cardiac output, but they're also very wet because they're full of fluid. So that is the sickest of the sick when it comes to an acute decompensation related to heart dysfunction. A new classification that we oftentimes use now is the INTERMACS classification, which is the International Registry for Mechanical Assist Support, Circulatory Support. And the cardiogenic shock patients would fall into the INTERMACS level 1, which is the crash and burn. And the other ones, of course, are less than that. With that said, though, there are stages. Shock is not all shock. Not everyone that presents in shock is the same. Some are the light shock, some are the heavy shock. So if you really think about it, there are some that go through stages. So everyone will go through an initial stage where they're compensated. Their heart's not working, the blood pressure initially drops, but then your body compensates for it. You go vasoconstricting, you may even lay down, you may actually pass out even, but you will compensate. If nothing is done at that point, then you enter the decompensated shock phase where your body specifically starts to target heart and brain for survival and sacrifices other organs. So ischemic gut, renal function that gets compromised, all of those things, and that's when people start getting really cold. If nothing is done at that point, then they go on to what we call irreversible shock. At that point in time, a multi-organ failure and vital organs are gone, and death in that point is imminent. So the question becomes, why is it important to know this? Why is it important to know there are stages to shock? Because knowing there are stages of shock allows you to be able to know when to intervene and when to actually give up. Because in medicine, of course, one of the things we need to know is when there's futility, when there's nothing you can do, sometimes the best thing you can do is nothing. Or more than that, spend time with family and doing the things that actually make the passing of a loved one easier. The way we look at it now is we look at based on whether they are on inotropes or not. If somebody's on no inotropes or very low dose single inotrope, they're in mild shock. If they're in moderate doses or one high dose, they're in profound shock. And then if they are on 2 high dose or 3 high dose inotrope or vasopressor agents, they're in severe refractory shock. And why is it important? Because at the end, timing is everything. If you come too early to a party, you're the only one there, and then it's no fun, right? If you come too late and the music is dying, there's no dancing going on, and it's gone. So you really need to find the best time to intervene. And in this particular case, then the question becomes, when do you intervene? The best place and best time to intervene for somebody in shock is right here. The moment you start anyone on an inotropic agent, this is the time to say, I have to do something more aggressive. Because in vast majority of situations, these patients will deteriorate. If you're very lucky, maybe they won't, but the vast majority will. If you wait until here, which is most commonly what happens when people start going on 2 inotropic agents, the chances of you being able to bring them back from the edge is actually exceptionally low. So another way to know, so let's say, for example, then you're in a different place and you don't know exactly what the inotrope requirements are. Well, you know the trouble is looming when the blood pressure is below 80, as I mentioned, the MAP is less than 65, and all these things are present. So if you don't have the ability to monitor them more closely, sometimes just clinical assessment is also helpful. Ultimately, once you make the diagnosis, once you stage these patients, and you know which stage of cardiogenic shock they are, then you actually have to intervene. And to do so, you need to know your tools. So actually, I edited this a little bit about 10 minutes ago. The vast majority of what we do actually is up front here. So revascularization, as I mentioned before, becomes very important, especially if it's an acute STEMI. But if it's not, then of course inotropic or vasopressor agents become important. And of course, as I mentioned, other mechanical support devices like balloon pump, ECMO, which is extracorporeal membrane oxygenation, or the actual short-term devices like tandem heart, Impella, or Centromag, and things like that can be used. But ultimately speaking, if the accessibility you have is just this, it's really important how to do that well. A second slide on basics of shock. Volume, volume, volume. And you've been told this in medical school, you were told this in residency, and you're probably told this in your fellowship. And if you're lucky, you're still being told today that ultimately speaking, undifferentiated shock in the ER should be given fluids to start until such time you identify the actual problem. Because if you don't identify and they happen to be hypovolemic, any intervention you undertake will compromise organs. So somebody is actually hypovolemic, you put them on any kind of vasopressor agent, ischemic gut is a very, very high possibility. One thing you also have to do though is make sure that you don't assume somebody's got cardiogenic shock just because they're coming to you. Oftentimes you get called from emerge because somebody's coming in shock, and because you're a cardiologist or you work in a cardiac unit, you assume it's cardiogenic shock. No, your first assessment is to know what type of shock is it. Then, of course, answer the question, is there mechanical complication? So always listen to the heart, make sure there's not a murmur or anything like that, something that would suggest a complication. There's that, before you do anything else, before you take a history beyond that, before you do anything that requires a little bit more time, there's a short medical stabilization period. And this is the moment you go and assess the patient, look at the patient and say, what do I need to do to make sure the patient doesn't die in the next 5 minutes? Once you've done that, then you go through what we call a rapid progression decision-making approach. You're talking to the patient. As you're doing that, you start to see the steps that come next. If that's not done, by the time you decide to take the next step, it may be too late. Now, from a medical therapy standpoint, there isn't very much as well. But one thing I will say is here. In patients with shock, in cardiogenic shock, traditionally speaking, the guidelines are simple. You stop vasoactive agents such as ACE inhibitors, beta blockers, and things like that. And more importantly, you don't start them on it. If somebody's in shock, you're not going to start them on a beta blocker or an ACE inhibitor, okay? However, one thing to always remember, and this is something that actually gets forgotten, is before patients are discharged from hospital, so if they survive the shock state, prior to discharge, they should be given all the evidence-based medical therapies. So ACE inhibitors, beta blockers, all of this should be started before they leave. If anything, if they survive shock, these are the patients who actually benefit the most from medical therapy at the end. So if they're discharged from hospital without medical therapy, they already lost a significant portion of their benefit. However, one thing to remember, let's say for instance, somebody comes in, it's not uncommon, someone who's had a previous infarct on all medical therapies to come into hospital with another episode in their cardiogenic shock. As I just mentioned, you stop all the medications. There's something we call a honeymoon phase with beta blockers. As you know, when you start somebody on a beta blocker, there's an immediate decrease in ejection or contractility. That happens because you're blocking the catecholamines. And over a span of a month, 3 months, what happens is the contractility increases. And then if anything, in some beta blocker trials, the ejection fraction increases beyond the baseline. So we know that there's an upregulation of the beta receptors over time. So what will happen then is these patients, especially who've been on chronic beta blocker therapy, are benefiting from that upregulation. The moment they come into hospital and you stop the beta blocker, for the short period of time, all these beta receptors are open. So if you start them on dobutamine, for example, they're going to have a fantastic response. And all of a sudden, their heart's going to get flogged. They're going to beat like crazy. And all of a sudden, you're feeling very good about yourself. Blood pressure is high. Everything's looking good. You walk away. About 2 days into it, all of a sudden, somebody calls you and they say, well, he's not diuresing very well. The blood pressure is soft now. And by third day, they're getting lower. That's because by the time that third day comes along, that beta receptor upregulation that occurred with chronic beta blocker therapy is now disappearing. So you really haven't seen the true extent of how sick they are in that early phase. So if somebody's on a beta blocker, when coming to hospital in cardiogenic shock, be very, very aware of the fact that even though it's very, very hard and difficult to treat them early on, the danger is actually at day 2 or 3, because that's when they might be even sicker. Okay? Let's talk about a few specific things. Emergent revascularization. So as I mentioned before, the shock trial, specifically shock 1, looked at the idea of fibrinolytic therapy versus primary revascularization. And what it shows that even though early mortality at 30 days was not different between the two modalities, by 6 months and then eventually at a year, there's a significant benefit to going for emergent revascularization in patients with cardiogenic shock. Now that did not pan out in the older population. If anything, in patients who were older than 75 in cardiogenic shock, they did worse, mind you, not significant otherwise, but did worse with revascularization. Now this is in a setting, of course, when there is the capability of going ahead and doing primary revascularization. But if there isn't, there is very, very important benefits to still going on with fibrinolytic therapy. Just because primary intervention was better than thrombolysis or fibrinolysis, it doesn't mean fibrinolysis wasn't better than medical therapy alone. We know that in this population based on the old trials, in the absence of primary revascularization, fibrinolytic therapy is still better in shock patients. The benefit is lesser, the mortality remains very high, but there's still a benefit to be had. So the second thing that you see then, after you've done the revascularization, usually, patient come in and they are in shock, as I mentioned, and then cardiogenic shock. So you're gonna go ahead and start on vasoactive agents. Because the vasoactive agents, there are too many to count. There are too many different things, and this is actually a slide that I put together and adapted from one of my colleagues. And if you look at every single one of these agents, all the way from dopamine to nazirtide to nitroglycerin, have a different effect on cardiac output, contractility, CVP, wedge, systemic vascular resistance, blood pressure, and heart rate, as well as diuresis. So why is it important? Well, commonly speaking, anybody in cardiogenic shock gets this. Dopamine and dobutamine. Guidelines used to say that, ACLS used to say that, and this is still the most common practice in the, probably in the world still. We know, however, that this is not quite as good. There was a beautiful study done in New England Journal published in 2010. And what they found, and I love the name of the study, the SOAP2 study. I don't forget it because it keeps me clean. So if you look at this particular study, they compared dopamine and norepinephrine. And if you think about norepinephrine, it made no sense. If you believe in the old understanding of cardiogenic shock, whereby everyone was vasoconstricted in cardiogenic shock, giving norepinephrine, which is a primary vasoconstrictor, made absolutely no sense. So when this was being done, a lot of people were very concerned that you're going to end up with organ ischemia, ischemic gut, and things like that as well. Nevertheless, because they designed it quite well with a lot of safety stops, they were able to actually go ahead and study. And what they found, interestingly enough, is that in cardiogenic shock patients, dopamine was actually associated with increased adverse events overall. Now this is, of course, a shock study, but specifically in the subgroup of cardiogenic shock was the case. So the question really becomes then, okay, if that's the case, then everything we understood about vasoactive agents, anatropes, and suppressors may be not quite as straightforward. So we really don't have a lot of data to guide our use of inotropic agents. So what do we do? Well, and again, I'm going to go back to the pulmonary arterial catheter. Hemodynamic tailoring is not something that's been shown to be beneficial in the advanced acute decompensated heart failure population. But in the shock population, when you don't know what to do with the vasoactive agents, this may be quite helpful. And it's something that we'll talk about in terms of hemodynamic tailoring. I'm going to give you some practical tidbits, and this is something I do in practice. So the two questions you ask when a patient comes in shock. Now this applies not only to cardiogenic shock, but it applies to any type of shock. One, what is the primary hemodynamic abnormality? And number two, what are the secondary hemodynamic abnormalities? So I'll give you an example. So in cardiogenic shock, the typical cardiogenic shock, the primary hemodynamic abnormality is a low cardiac output and low contractility. And the secondary hemodynamic abnormality is a high filling pressures on the left side, so a high wedge pressure, very high systemic vascular resistance because they're vasoconstricting in adaptation to the shock state, and of course, low blood pressure as well. Usually the CVP in that situation can be normal, sometimes low, sometimes high, so it's really not that different. So if that's the abnormality, then the question becomes, what is your hemodynamic goal? Now, if you don't have a PA catheter, you can easily get, so low cardiac output, they may be tachycardic, they can be vasoconstricted, so it can be cold, the blood pressure is going to be low. So there are surrogates of hemodynamics that you can use clinically. So usually in this kind of situation, they'd be cold, they'd be tachycardic, and blood pressures will be low. And urine output will be low as well. So the hemodynamic target and goal in this particular case then would be primarily to increase cardiac output index and to increase contractility. And the secondary then is to decrease the wedge pressure and decrease the SVR and increase the blood pressure. Okay, so let's go back to my screen before. So let's say, for example, now you understand what you need to do. Well, number one, you need to actually increase cardiac output. All right, so these medications will do that. Then you need to decrease the CVP. Well, these medications do that. And you also need to decrease SVR. That does that as well. But other medications also help in decreasing. Wedge pressure, nazirtide, nitroglycerin, loop diuretics, it drops the wedge pressure and also drops the SVR. How about blood pressure? Well, dopamine does a fantastic job at increasing, a good job, not fantastic, but a good job at increasing blood pressure. Norepinephrine, epinephrine, vasopressin, phenylephrine, all of those do a very good job at increasing blood pressure. Now you're stuck here. Okay, so I know what the primary hemodynamic abnormality is, and I know what the second ones are. And looking at all these medications, none of these solves all my problems. Because dobutamine and are the closest because they help increase cardiac output, they decrease the wedge pressure, they decrease the SVR. But unfortunately, it does not increase the blood pressure. So that's the reason why oftentimes you need to consider the possibility that even in situations when you're first starting out, you already may know that you may require 2 different medications. And this is perhaps the rationale as to why medications like norepinephrine may have been better than dopamine in some cases, especially when used in combination. So this is an approach that can be applied to most patients. And as I mentioned before, because shock patients are difficult to enroll in studies, and so even the shock trial had a very difficult time enrolling them. Sometimes you have to go on clinical acumen, you have to go on what you understand. And in this particular case, hemodynamics is something that's easily accessible, but also easy to understand, and of course you can target. As you go along, however, anybody with cardiogenic shock should be assessed for the possibility of the uncommon. This is a VSD. VSDs, of course, used to be associated with a very, very high mortality, but now with surgical intervention, mortality remains high, but survival is actually improved, especially early, caught early with early intervention. So if you look at the actual shock trial, they had a registry that followed all these MI patients. The mortality with non-surgical intervention was 96% in the VSD population, and that decreased to 81%. And many of us believe that the VSD survival now is actually more like the 60 to 70%. Still very, very high, but surgical intervention, especially with early diagnosis, can be improved. This is a papillary muscle rupture, okay? In the shock registry, the overall mortality was 55%, but without surgery, it was 71%. Now, this is a situation where you have a significant improvement in survival with early surgical intervention. So this is a very good population. One thing to remember is that when you have somebody with acute MI, and if in your particular center you don't have accessibility to surgery, you have to temporize them. So in this particular case, the best way to temporize them is to, again, look at what's happening. If the mitral valve is ruptured, you actually have severe MR. So the best thing you can do is decrease afterload. So a balloon pump, for example, in this particular situation would be quite helpful and something that can temporize patients to the point of surgery. If we don't have access to a balloon pump, sometimes nitroprusside, especially if the blood pressure is still reasonable, which is not unusual early on in the process, nitroprusside can act as a balloon pump type analog by decreasing the afterload. The only difference, however, is that with nitroprusside, they don't last very long. So the moment you start nitroprusside, one, they may drop their pressures immediately, or even if they don't, within a span of probably an hour or so, they're going to start deteriorating. So transfer to a center with cardiovascular surgery becomes quite important. Free-roll rupture, of course, happens, and we all used to believe that these are 100% mortality. We now know that's not quite the case. There are some patients who get a free-roll rupture, and they contain it in the pericardium and develop a pseudoaneurysm. So again, it's very important to identify these patients as well. More times than not, surgeons will not want to operate in them, so they'll self-select. The ones that survive are the ones that would have survived anyway. But it is still nevertheless very important to realize that these things happen, especially in patients who get late fibrinolytic therapy. So somebody presents with a late STEMI who gets thrombolytics or fibrinolytics are a much higher risk of developing this as well. I'm going to spend a little bit of time talking about advanced therapies because, of course, as I did the poll, there's not much available in most of your centers in terms of these kinds of therapies. But talking about balloon pumps, and this is something that we use not infrequently, but the evidence, of course, is lacking. I'm going to just go fast and past that. But the balloon pump, of course, it drops the systolic pressure. It increases diastolic pressure, which allows better perfusion of the coronaries as well. But it also drops the afterload. So that's the reason why, from the perspective of hemodynamics, it makes a lot of sense. Unfortunately, the data, which I'll show you later, is really not there in supporting the use of balloon pumps in a shock situation. There are percutaneous devices that we use in our center. Impella, which is a percutaneous device that goes into the ventricle and kind of just pulls blood from the ventricle into the aorta. It works okay. The smaller 2.5 really doesn't help you very much. If somebody's truly in cardiogenic shock, it really doesn't help very much. ECMO is something that we use frequently because it allows you both right-sided and left-sided support it also allows you to oxygenate if somebody has severe pulmonary edema. And this can be done in the cath lab, just percutaneously. So it is something that can be used in situations where you don't have time to take them to the operating room. Tandem heart is, again, a device that goes through the septum into the left ventricle, or the left atrium, sorry, and then pulls blood from the left atrium, and then, from the venous system, and then pours into the left atrium through an oxygenator. Long and short of it, though, is that all of these devices have pros and cons. Some of them take a long time to put in. Some of them are really not very good. Some of them only provide left-sided support. But ultimately, if it is something that you're thinking about doing, in most of the centers that I visit talking about shock, I suggest if there's one thing that you want to learn how to do is ECMO. The reason why that is most centers will have accessibility either locally or otherwise to cardiovascular surgery. And ECMO is easy because all it is a modified bypass circuit. It's a smaller circuit, of course. They use less prepping, and there's a lot of different things. But any center that has bypass surgery availability can start an ECMO program, and we've helped a number of them start one. Of course, there's heart transplantation, but it's really not appropriate in the acute setting. We don't do heart transplantations acutely anymore because we have the ability to put people on ventricular assist devices, which allow us to bridge them. And even in the level 1 intermax, which is a crash and burn, cardiogenic shock patients, the mortality, especially in centers that do this very often, is actually quite good. The caveat here, of course, is that this data is very selected because these are only for the patients that went on to get an assist device short term. But of course, a lot of the ones that didn't get it because they were too sick or didn't make it. And maybe what I will do is go quickly over the evidence and suggest that, again, balloon pump, no evidence is beneficial in shock. So really, it's not something that's recommended very much. And that same thing applies to most other organs as well. I'm going to run through the slides very quickly because these are really not that relevant. I like this slide, of course. So ultimately then, the better way to approach it is to have the ability to early diagnose, to have a high index of suspicion, and to pull the trigger on more aggressive interventions earlier rather than later. So if somebody does present with severe shock, you do maximize all medical therapies, the inotropic agents, and I would even consider a balloon pump if you don't have any other options. And making sure that in that situation, if they don't improve, then consideration for salvage type therapies, if available to you, could be made, like such as device. If not, in refractory shock patients who don't respond to initial medical stabilization, their mortality is approaching 90% or more. And that's when, of course, palliative measures become important as well. And ultimately speaking, what I usually tell people is no matter how well or how badly shock goes, it's always easier when you have a team. So if you work together with people that work well, whether ICU, surgeons, nurses, physiotherapists, and counseling, chancellor, and people like that, it allows you to deal with the situation better. And whether the outcome is a good outcome or not, you as a team can deal with it much improved. Thank you very much.